Welcome to Kinked Wire. I'm your host today. My name is Lei Yu. I'm the secretary for Early Career Section and an interventional radiologist from University of Nebraska Medical Center. Today's episode is a part of the new ECS multi-series in collaboration with Kinked Wire, where we feature conversations specifically designed to early career IRs. It is my great honor to introduce our guest today, Dr. Parag Patel. Welcome, Dr. Patel.
Thank you.
You are so famous in the IR field. I feel like there's no need for introduction. We do have listeners who are medical students or trainees that are new to IR. So I will do a quick introduction for them. Dr. Patel is an interventional radiologist and a professor of radiology at the Medical College of Wisconsin, where he serves as vice chair and a program director for the integrated IR residency. Dr. Patel was president of FSIR in 2022 to 2023. During that time, he has led key initiatives to support members and advance patient care. Dr. Patel is also a primary investigator on multiple IR trials and a very strong advocate for our field. So welcome again. Today, we'll be talking about early career pathways to program director. But before we dive into that topic, let's talk about what drew you initially to interventional radiology.
So that's a long time ago now. For me, it used to not seem that way when I could tell. But my era of interventional radiologists often have a very similar story. We didn't necessarily know about the field coming into medical school or medical training. In fact, most of us came into it by chance. And for me, it was during a third year clerkship in surgery, where we were frequently calling on the interventional radiology team to help out with post-operative issues that our surgical patients were having. And I was of the mindset that medicine folks did the medicine work and the surgeons did all the procedural work largely. You know, obviously there are medicine's proceduralists, but the interventional radiology team seemed to be the go-to. And I happened to follow one of my patients who was having a post-operative bleed down to the angio suite. And that time they used to call it something that we no longer use, terminology called special procedures, or a different part of the hospital, and went down and saw an angio occur. First time I'd seen something like that. Saw the anatomy that I had frequently referred to or studied on anatomy textbooks come to life on a screen, and then a catheter work its way to the source of bleed and embolize. And that right there, sort of when you see it, you know it. And I think many of us have that experience, our first exposure to interventional radiology or the field, whether it's an ablation, an embolization, a stent, you name it. It clicks and you sort of know this is something I really want to learn a little bit more about. And that did it for me. That began an interest to investigate more about the field and pursue it as my career path, even though that meant going through a very traditional diagnostic training pathway, which was the model back then, because the end goal was to be able to do what I do now, which is obviously a very different pathway now for most young trainees.
Yeah, I actually have a similar story. When I was a third year on OB, we had a postpartum bleeding in the middle of the night, and the OB was not able to control the bleeding, so they pick up the phone and say, call IR. So I followed the patient to IR and witnessed they doing the uterine embolization. I'm like, that is amazing, you know. Uh, let's talk about a little bit about your training back then. Like it's very different probably than today. So if you can reflect a little bit on that.
Well, my training, as far as residency and fellowship training, I would say came in an era where interventional radiology had already been identified as a subspecialty within our field, but I would say that largely the field was still quite varied or disparate with regards to how it was practiced. Training technical skills, I think, was comparable across programs. Basic angiographic techniques, catheter and wire skills, non-vascular tube management, drainage placement, so on and so forth. But really taking care of the patient, learning how to manage the disease, and actually entering into that era of competing specialties, doing this similar work perhaps that we do, or overlaps with some of the stuff that we do, became a really hot button issue within the field. And I recognized that if I was going to pursue this field, that I kind of fallen in love with from senior medical student to 6, 7 years later as an attending. I really needed to gain some skills beyond just the technical. And so for me, the fellowship training was important, but it needed to be one that didn't just have a volume of cases, but actually took ownership, like really serious ownership of patient care. And that's what led me to pursue my additional training from the Midwest, where I was born and raised in Chicago down to Miami for a really formative year for me.
Yeah, that's very good advice for our trainees to pursue their IR training. You have been always very actively involved in training residents and fellows. When did you realize that education would be a very central part of your career?
Good question. I think as an eager young interventional radiologist, and I think many can relate to this after finishing training, it's a long road, and you want to take care of patients, and you want to be impactful to the group. You feel I felt a sense of ownership of the practice that I was joining here in Milwaukee, and a duty to try to give back in some capacity. But I also knew that day one or even after just a year, there was no way I was going to be the established expert in anything. I had senior partners who were more than qualified, capable, and quite frankly, to that date, built the practice to where it was, and they were looking to grow it more. But the thing I thought I could help out with almost nearly from day one was connecting with the trainees, the new fellows that were coming right behind me in the years to follow, and organizing the educational program to better suit, I think, what the new trainees needed, younger trainees needed. And I was closest to that, having just been through that. And so it was the first thing I could do beyond just my clinical practice and the work that I was trying to build was to give back. And obviously, I chose an academic career, so that's not necessarily the case in a private practice. But I think looking to find what are the ways I can give back beyond just obviously my clinical responsibilities and duties, covering cases, covering call, seeing my patients on rounds and clinics and consults to build the practice with your colleagues, but also what are the other areas, perhaps in practice management, perhaps in building multidisciplinary programs, being present at conferences or tumor conferences, you name it. There's other things that occur that fall more on the administrative side of things. And for me, the thing that resonated most, I felt more interested in, was in education. And so that's where I took an interest in not running any educational programs, but taking a look and giving advice to maybe how we could streamline things, how to better organize, reestablish our goals and responsibilities, expectations, something as simple and mundane as that, but also something that I think others didn't have the time for, and frankly welcomed someone else who was eager to do that, to take on.
I often hear like young IR, early career when they came out of training, the first couple years, they actually feel like a sense of an imposter syndrome when they connect with their training. It's like I just literally 1 year ahead of them.
Mhm.
So how do you feel like what can you say for them to overcome the imposter syndrome if they want to put their role in educator?
Well, it's first of all, it's real. We all have it to some extent. It's sort of the audacious. I finished my training. I'm now an interventional radiologist, potentially board eligible or board certified, depending on the timing of your oral exams. And to say that I'm equal to all the other IRs in the practice seems a lot to sort of stand on. It was for me, and I had, as I said, partners or colleagues that were 10 years ahead of me and had a wealth of experience and knowledge. So I had that too. But what I did know is I know how to relate to people and trainees, and I felt like I could give the time that deserves to be good at that, to at least try to help guide and support in the ways that I think a struggling trainee who may be lacking some confidence or struggling with a specific technique or wanted to learn how to approach case planning, things I could help with. Obviously, volume and experience is something you can't make up for. You have to take that. That takes time and it takes volume, as stated. So I think accepting that imposter syndrome is real, but it's everyone before you had it as well before they establish themselves. And there's only one way to do that, and it's to do the work.
Yeah, just do it. Yeah, I remember first year coming out, there's a period of time I specifically avoid training. I'm like, you know what? Let me put my feet down, doing more cases, building up my practice before I feel like I'm qualified to teach other people. So certainly imposter syndrome is real and we'll, like you said, we just have to do the work. And so since you're taking the interest in education in your early career, what experiences has helped you prepare to become the program director?
Well, as I mentioned, I didn't have eyes on being the program director when I first started here. I wanted to help build the vascular practice and take on some of the more complex era of vascular intervention that was happening, continue to build and support the growth of the interventional oncology practice, but knew that organization in the education program, or to take our program, training program, to the next level, I felt like there was an opportunity there. And so I had provided some feedback on what I had seen from my own training and my own experiences to where we could take the pieces that we had, which was already pretty strong, and organize it in a way to become just this really strong program. And so I put the effort in to sort of see where other programs have lied and where we could be in that. And I think we felt we were a strong program, but I thought, why not have the audacious goal to be one of the best programs in the country? And um, there's no ranking that tells you where you're at, but I think if you strive for something really, really good, you get pretty close to it if you keep pushing yourself towards that goal year in, year out. And coming close to 20 years, we've had that specific goal, and we've developed a really consistently strong training program that we're really proud of. And because of that, in the first 3 or 4 years here as a young faculty, when it was time for a new program director, the sort of the natural person that the group had identified was me, and I was happy to take that on at that point because I'd already put so much work into organizing the program.
Oh, that is awesome. I feel this is a very similar probably experiences for a lot of early career people. They often have to take the lead in the area, even though they do not actually have the title or they do not have the support. So, how long have you been a program for your institution?
The program director, well, it's been over a decade for sure. I joke at the APDIR meetings that I often felt like right amongst my cohort, or maybe on the younger side of program directors, and now I've quickly become more the senior statesman. And I'm happy to say I've two younger partners who are involved as associate PDs or PDs of the independent programs, and they'll be leading the program in the years to come. Um, but it's been well over a decade, and I think you said something earlier that I think is important to maybe emphasize. I was didn't recognize it at the moment that I was doing this, but I look back, and it was really impactful, was the willingness to do the work without having the title. And I think at the time, while I might have hoped for an opportunity to establish myself in some capacity clinically or leadership wise or programmatically, I was doing the work that often might have been categorized as the program director or as a leader in education, or in some cases in our clinical practice. But I didn't have the title and I didn't look for it because I still needed to establish myself. It was a way to sort of overcome the imposter syndrome. And I think early on for trainees to feel comfortable and willing to do the work without the title, because that'll come. And it did, frankly, within, just a few short years. Um, I completed my board certification as everyone else does, which doesn't happen until you're out for a little bit or a year or so. And um, lo and behold, a few years later I was, and now I've been the program director for not quite 15 years, but coming close to that.
Yeah. So another piece of advice would if you could give young early career IRs, when you're balanced, be the try to establish your practice and you're trying to explore endeavor in education. Often we don't have time. Like, how do you negotiate more time to do the administrative work? Maybe some other partners not interested of doing. How to find the balance between put a lot of effort in education versus building more clinical like existent presence.
This is a hard one. Admittedly, protected time is not something that's given to everyone. We didn't have administrative time and barely had academic time when I first started. We evolved to that a few years in, once we were bringing finally another hire into the practice after me, and there was an identified need to be a little more academic. We were very clinically strong, and most of my additional work, like I've just described, was being done in the evenings between cases or even on the weekends. And so Um, I don't necessarily say that's the only way to approach this because I know that that's hard. It was hard for me at the time, and I had a young family. Um, but I tried to figure out how to be the most efficient I could be. If I was on call for the weekend, I was happy to be in doing cases that needed to be done to cover, do my part as part of the group. I actually scheduled myself in the office to do some administrative work. So I was here either way. I sort of kind of expected it. And for the first several years, 5, 6, 7 years, that's how every call weekend was. Now I tend to do less of that. I'll come in for the cases I need to come in for, run and see patients as they need to be seen, but I'm not parking myself here as often as I used to. But it was a habit that came early because I used it for case preparation for the coming week's cases, for developing a handbook for our trainees early on, and the work that it takes to develop that, or lectures that I wanted to help provide, or running a journal club for our trainees. I just urge our trainees to find, how to be really good at multitasking and time management, because you're not always going to get protected time. But once you're a program director, as the ACGME requires it, you do get protected time. And so now you've earned it because the title is there, but there's work to do in that capacity, right? Um, I'll tell you, as I progressed to other leadership roles, I didn't ask for additional protected time to serve on the executive committee or as president of the SIR. I was committed to trying to do that work in the administrative or academic time that I was allotted, and oftentimes it meant some evening meetings and calls and some stuff on the weekends, and certainly on days that wasn't afforded protected time. And you just try to make it work, because nothing ever fits perfectly in a box. On the one day that you have free time or academic time blocked, it's often not the only time where this work needs to be done.
Yeah, that's very practical advice. You really need to be very good at multitasking. So this one I was really interested personally. So in your early careers, have you ever thought about you will be one day the president of the SIR? Has that ever crossed your mind?
No, not at all. It was imprinted on me very early in my career, the importance of SIR. Um, I don't know that everyone gets that from their program directors or from their senior faculty mentors, but we're all of us that call ourselves interventional radiologists that have gone through the training, regardless of academics, private practice, in a multi-specialty group, a DR group, or a standalone IR group. All of us that have gone through that training pathway are interventional radiologists. And there's really only one group that's going to support that professionally, and it's the SIR, in every capacity that needs to be supported. Education, continuing education, guidelines, health advocacy, economics, you name it. And so it became apparent to me, as a young trainee in an early career, this is where I wanted to at least park some of my home. This was going to be the place professionally that I wanted to be part of. There's many other radiologic societies or disease state type specialties or organizations, but the only one that represented interventional radiology was the SIR. And as I said, that was imprinted on me by early faculty mentors and partners who saw that importance coming together. All the giants in our field, and I certainly don't consider myself that, but the ones that I looked up to were all leaders within the field, whether they were titled or just established giants in the field who'd done a number of early clinical trial work, device work, or just led the evolution of our specialty, did it as identified interventional radiologists and largely through the SIR. And so for me to even have the audacity to think that I was going to be the president would have been really silly, and that never crossed my mind. And if I look back, it was a series of incremental roles and steps that I took on as the opportunity arose. And I tried to give it my best and said, okay, someone did this before me, and now it's my turn to give it my best effort until it's time to hand off to the next person. And each one of those led to other opportunities and led to greater opportunities until the leadership opportunity arose. And even then, I wouldn't say I was reluctant, but I felt it was such a big role that if I didn't ever get it, it wasn't going to be a concern for me. But my biggest concern was if I was to be asked to do this or be involved in this role, that I had to give it my best, because many other in our field, all of my colleagues around the country were counting on it and deserved that effort by our leaders.
You're certainly an inspiration for a lot of young trainee like me, or early career hire like me, because just listen to when you talk as the president for the SR annual meeting, it is a huge inspiration. So thank you so much for that. So now let's go back to the education track. What advice would you give to the early career physicians if they have, aspire to a leadership in education? So what could they prepare themselves?
Well, one, I'm glad we have such an organized early career section. It's, when I was coming up through leadership, the early career section was sort of in its nascent forms. It was the RFS, which because we didn't have the integrated residencies yet, that was really where we were drawing on these young trainees, mostly medical students or diagnostic residents who were focused on IR. Now we have an ECS, which is really, these really early 5 to 7 years out trainees who can organize themselves, have organized themselves into clinical areas and into just general broad divisions with that represent the SIR. And those are volunteer committee work, get placed on committees that are of the larger SIR and continue to try to do the work. Many people sit on committees and you're on the roster, but we all know that there's a handful or a smaller group of individuals who actually do the carrying of the heavy work, if you will. And I think if you find the passion, for me, it happened to be education. But if it was something else, and I didn't have the passion, I largely would have sat on a roster and not had an impact. I put myself in things I like to work on and with people I like to work with. And it's easy to find that in our field. And so put yourself in those early career sections, whether it's in outreach, whether it's in education, whether it's in economics or guidelines, and then do your part. Be present, uh, give feedback when it's needed, take a lead when others are taking a passive approach or taking a step back. And I think oftentimes because it's something you're passionate about or you believe in, you'll find it easy to do that. And that little bit of extra effort will start to identify or highlight yourself as someone who might have a greater opportunity for other roles. And I think that's largely when I look back what happened. It wasn't designed that way. I didn't have an intent to do that with the hope of something greater. But I think I aligned myself in things I really enjoyed with people I liked. Um, and the last thing I'll say is I had a lot of support from outside mentorship, from my own institution, but even outside my institution. As I got to meet people at the annual meeting, not unlike how you and I met at annual meeting this past year. Um, we've never worked together, but that connection lasts. And reaching out and connecting by phone, text, or email is an easy thing in our specialty. And people will give their feedback and support you. And I've certainly done that to others who reached out to me. And I was the beneficiary of others who were willing to provide that feedback when I asked for support. Um, that's what makes this a lot easier to approach, I think, and accomplish. So get involved. The SAR needs strong volunteer leadership, not just names, but people who are going to do the work, want to do some work, move the field forward. And then you'll see quickly that other opportunities will come up because it's needed. And and I think, frankly, I was of an era that took the mantle from a great generation of IRs who brought it to where we were, and now it's up to this current generation and yours, just behind it all, to lead that forward. And there will be a small group of interventional radiologists who end up taking that role and responsibility for the rest of our specialty. And I think that's how it's always been, probably to some extent. We've growing bigger and bigger, and we have a different focus than we did 20, 30, 40 years ago. But our leaders are going to lead us, and I think many of them probably don't realize that they're going to be that in the future, sort of like how I was when I was in your shoes. A few years out, I think I had no idea that was going to be in the cards for me, but they tend to show themselves in time.
Yeah, that is awesome. I do have to emphasize that mentorship is such a great component of our career. Either you are now in the mentee shoes, or in the future your position would be on the mentor side. That's what kind of like us together. So next, so we're towards the end of this podcast, and let's reflect. So if you could go back in your career, look say, oh, when I just come out in my early career years. Um, Anything would you done differently?
Um, yeah, try not to live life with much regret. I mean, there's always things you could look back and do differently. I also think that the things that you make mistakes on, if you truly are self-reflective, you learn and how to be better for the next opportunities. Um, I'm certain there were committees that I signed up on or thought I'd be part of that I really wasn't impactful on. And in retrospect, I can imagine I just didn't have the passion or enjoyment to work on that, or perhaps the bandwidth. And frankly, what I've come to appreciate is we all have limited bandwidth, and saying yes to many things in the hopes of accumulating a lot of roles, perhaps, for as simple as a CV, or more importantly, to reflect your experience isn't really as helpful as a meaningful experience and opportunity to show some real growth. I can talk to people much more about my experiences in education and program building and running courses and developing content much greater than I can talk about our at the time, a few years out, talk about economics, let's say. As you grow
Mm.
up in leadership, you start to learn the economic side and the health advocacy side and the importance of all of it. But I just that wasn't for me in my early career. I wasn't the economics person, let's call it, but I knew about billing and coding, the importance of it. I really wanted to focus on education. And so that's largely where my passion arose, and it probably showed because I was willing to spend those evenings and weekends doing that when I could have probably called it a day, and I would have if it was another other focus.
Yeah, absolutely. So let's looking forward. So what's next for you? So any new goals, projects in the near future?
Um, you know, I've never really worried about next. I will tell you, I didn't look to be the president, but it came about, and I didn't look to be on the board before it came about, or even the program director here. As I've mentioned, I have some wonderful partners here who are going to assume the roles as program director in the coming years. So I look forward to being a mentor and continued support to how they leave the mark on this program. I just took a new role on as vice chair of education in our department. And so there'll be opportunities to help overall education and leadership in the department. Um, but I've got a lot to give yet. I still have, a long way in my career, I believe. I've focused on vascular work largely is how I'm probably characterized as a interventional radiologist with arterial, venous, and aortic work. And I'm on the board for Viva, which is a multidisciplinary group that has done some great work in that arena, focusing on vascular diseases and really looking to represent strongly IR's role in that type of work. And then continue to mentor and guide. I was a beneficiary of that. And I think those people, some of them were never really identified as leaders, but made an impact. And so if I hold no other future leadership mantle in my career, I'll be fine. Because I suspect that some way across the way, some of my trainees or others I've got to meet along the way may benefit from some of the support or advice I can give, hopefully, in the years to come.
Thank you so much. I do see there's a picture of you holding a tennis bracket. So I suspect you're also gonna spend a lot of time on the tennis court.
Well, that's actually that was a profile done from Interventional News. Many might be familiar with that series, and I have a lot of interests and hobbies. The tennis racket is really an ode to my daughters. I have two teenage daughters. Their primary sport of interest is tennis, although they enjoy skiing and sort of an active lifestyle overall, I would say. We like to travel and hike and do many things. But so I'm a tennis dad or a coach, if you will, of sorts, mostly cheerleader, I guess I would say. But for them, I'd follow them anywhere to support them in that endeavor.
Oh, that's awesome. For that aspect, I'm a soccer mom, so I go to a lot of soccer practice and try to, finish cases on time so I can mirror the practice at the game. So, thank you so much, Dr. Patel. Thank you for sharing your journey with us, and thank you for always being a mentor, supporter, and inspiration for our early career IRs.
Oh, it's my pleasure. It was great chatting with you, and I look forward to seeing you some more at future SAR meetings and hopefully other early careers interested in moving the field forward. Thanks so much.
Thank you.